our next speaker, Dr. Matthew Zawadka, who is also another established star in POCUS education. If you've attended any of the ESICM POCUS offerings, and now has delved into neuroultrasound world as well. And I'm very proud to have him as a collaborator for one of his research studies as well. He's going to talk about TCD, particularly in hepatic encephalopathy. Matthews, the floor is yours.
Thank you very much, Arti, for this kind introduction, and I will jump straight into the presentation. This should be a very brief overview because we have 10 minutes for quite an extensive topic, which is not really well researched, so it will give you just a taste what I was able to find and share a little bit from our experience of our center. So just to make sure, do you see the slides advanced?
Yes, sir.
Thank you. So this is my disclosure to work with a couple of organizations, and unlike other speakers, I'm not a TCD expert. I'm just an intensivist with the interest of management of liver patient, which we have quite a lot in my institution. What is the current understanding of the physiology? So we all know that ammonia is related to the increased cerebral hypertension. It's mostly due to the problem of the detoxification of the ammonia through failing liver. And then ammonia is transversed into glutamate, which is osmotically active and actually cause the brain swelling. This is what we thought before, but obviously the reality is more complex than we initially thought, and this is far more pathway that could actually contribute to the increase in intracerebral pressure. And what we know now that is multifactorial. There's also a huge role of inflammation, cytokine cascade, bile acid, lactate, and other which will cause brain barrier permeability increase. So this is why the group is quite heterogeneous. It is difficult to draw a conclusion what is the main factor causing the hepatic encephalopathy. So how severe is this problem in a liver population? So if you see in the data, if you look at the data from the 80s, nearly 80% of the patients have problem in the increased cerebral hypertension, and it dropped in 2000 to nearly 20%, mostly because of our improved management of this group of patients. And you can also see a huge decrease in the mortality. So based on that data, we know that in treating the intracranial hypertension in the liver population is very important to actually improve our mortality and morbidity in this group of patients. So what is the pathophysiological sequence of the hepatic encephalopathy in acute liver failure? So we could identify at least two patterns. This is at least what I could find in the literature. So there is something like a high resistant pattern and hyperemic pattern. So high resistant pattern is with the increase of pulsatility index, PI, and this is mostly due to the ammonia and the glutamate toxicity and cause cerebral edema due to cytotoxic features. And the other one is hyperthermic pattern, which is with normal PI and increase in cerebral blood flow. And this is the other mechanism, which is most likely due to hyperinflammation, autoregulation dysfunction, and the abnormal vascular reactivity. And this is cause vasogenic cerebral edema. Both of this pathway could increase ICP, and both could lead to herniation, and they are also could happen in the same time, these two pathways. So there's a couple of interesting study which are, let's say, proof of concept in this cohort. So one is analysis of a hyperammonemia in a non-hepatic patient. So in this group, when they stratify based on the level of ammonia on the patient with not impaired liver function, there was no significant difference in the cerebral flow velocities between the group with different level of ammonia. So this suggested that in a hepatic group, there might be other mechanisms that are involved in the cerebral flow regulation. But on the other hand, in this group of patients, so non-hepatic hyperammonemia, the optic nerve sheath diameter was increased. So this is pointing out to some different mechanism that is involved. Another study, this is point out to the mechanism, is a very small 7-patient basically case study, patient with acute liver failure with high grade hepatic encephalopathy. They hyperventilate those patients to try to preserve the cerebral autoregulation, and they managed to do it in a 5 out of 7 patient, pointing out that cerebral vasodilatation may actually play a role in this group of patient and impede auto regulation, but still it's a very small group of patients. So what is the role of monitoring ICP in this cohort? So we know from the surveys that only about 50% of the European transplant centers use ICP monitoring, and we know from more recent guidelines that is not longer recommended. I will show you in the end. And this is not surprising that most complication is from the intracranial hemorrhage. We know this group is very prone to bleed and in the coagulopathy. So this is the review of the literature coming from the acute liver failure cohort. There's not a lot of study, but still this is the cohort that is the most well established in the liver literature when we put the TCD in a picture. So this is one of the biggest studies that I was able to find. So cohort study retrospective of around 100 patients. They actually followed up those patients until liver transplant. So up to 50% of the acute liver patients have a PI index more than 1.2, and those patients with the increased PI index had worse prognosis. So they required more sedative drug, they required more vasopressors, and they also did poorly. But most of these patients were able to stabilize their PIs within 1-2 days after liver transplant. Another study on fulminant hepatic failure coming from Japan in 2009. They perform analysis of the TCD and as long as other biochemical properties during the liver failure. Within most of the extrahepatic support they perform were either plasma exchange or continuous dialysis. So when they observe decrease the ammonia, total bilirubin, and other liver parameters, they will also able to decrease pulsatility index in this cohort of patients. And in the cohort that they were able to identify that the PI index was below 1, they have better long-term prognosis, but also in this group of patients, the overall prognosis was quite poor. But this is a very small sample study. So another interesting cohort is patient with acute on chronic liver failure. So we know for that in this group of patients, the pathophysiology is very different and they behave also very differently than acute liver failure patient. And from our experience, this is also a group that is quite unpredictable in terms of intracranial hypertension. So there are very few studies regarding this group of patients. One of the interesting studies is, again, very small, only 8 patients. So those were patients with acute and chronic liver failure that undergone extra corporeal support like Mars device, and they follow up those patients in terms of TCD mean velocities, and ammonia and bilirubin were also matched with the increased mean velocities. So this actually proves that extracorporeal support go hand in hand with the also increasing the in the mean velocity and improved brain perfusion. But again, only 8 patients of this cohort, but we don't have a lot of studies in this group. Another group is patients with cirrhosis. We have a little bit more studies, but all of the studies are also rather small. They are most is retrospective in Nature. So this is one of the biggest studies. So almost 120 cirrhotic patient and compared with the healthy controls and hepatitis. And from this study, they were able to correlate pulsatility index and resistive indexes with increase in ammonia, bilirubin, albumin. So this group with increase in ammonia and other where had an increase in PI and index. So this is something that we also observe in our group of patient. So in terms of research gap, so unfortunately there is no a single randomized controlled trial that will compare TCD-based management and patient outcome. There are only small single center studies and case series, or even so it's really difficult to draw conclusions. We know that the liver cohort is very heterogeneous group. So in the same group, we have acute liver patient, acute and chronic patient with alcoholic liver disease, or many different autoimmunological problems. So we know that they may behave different, and they may also different pathomechanism that actually leads to increase of ICP. We know that there's also problem in the literature identifying TCDs and TCCDs because we as intensivists with not a lot of experience as neurologists with TCD in our hands, it might be better to use TCCD, which we are more familiar during the point of care ultrasound. Literature also is not very clear about location of the vessel that was insonated. Was it a proximal distal M1? Was maybe M2? Did they use angle correction? So the methodology is not could be maybe improve in the literature, and maybe the differences will be a little bit different. Most of the studies focus only on MCA insonation. Would be different to try to check on the PCA on the patient undergoing hepatic encephalopathy, and there's not a single study in the liver cohort that would analyze waveform like P2 to P2 transformation. Education gaps. So in terms of dedicated literature to liver patient and increasing ICP, there is not a lot of resources. So a couple of paragraphs in a general neurointensive literature. There are courses that are obviously dedicated to intensive care in general intensive care, like one that is during SICM lives, or at least that's what I know of in Europe. That's a couple of courses in Italy and UK. We also started one course in Poland this year. There's no dedicated literature in terms of use in TCD in acute liver patient cohort. So we would rather extrapolate what we already know based on the general intensive care population. What are the guidelines about the intensive care liver patient? So there's one with Society of Critical Care Medicine, which no longer recommend using invasive intracranial pressure monitoring, mostly because of the side effect and hemorrhagic complication. European Society for Study of Liver pointed out that transcranial Doppler is a useful, not invasive monitoring tool, but evidence level 2. And the most, I think, optimistic about use of TCD is Indian National Association of the Study for Liver Consensus, which stated that ICP monitoring is not recommended. Non-invasive ICP monitoring can be done in all patients with acute liver failure with grade of evidence moderate and recommendation strong. So maybe just two very brief cases that to signify the clinical problem that we have with our liver patient. So this is a case of acute liver patient, 45 years old guy with quite severe hepatic encephalopathy, intubated and admitted to ICU with significantly elevated ammonia at 155 and initial pulsatility index on admission 1.8 just after implementing hemodialysis and other ammonia lowering medication. We were able to to lower the PI to 1.6, and after liver transplant, the pulsatility index normalized. So this is also a good example and something that we would expect of acute liver patient, that with increase of ammonia will observe also increase in ICP in this group of patient. And this is another case with acute on chronic liver patient, on a patient with the alcoholic liver disease, 33 years old female, with also very high ammonia, so probably is the highest ammonia I have ever seen, so 950, and very low sodium of 121. So based on this biochemistry, I would expect this patient to be basically, I think, herniated due to very high ICP, but to our surprise, the TCD looks rather normal. And I think this is one of the surprising things about pathophysiology of acute and chronic liver failure, that we just don't know how patient can adapt to the higher level of ammonia and what compensatory mechanisms do they have. So I think this this is a very difficult group to actually manage, because we don't know what's going on in terms of their ICP.